Well, I have the mic, so I'm going to ask a question. I'm going to go back to, it's a very practical question, but it has to go back to the training. Something was mentioned about the healthcare provider training. But what about agency adoption? I'm very interested in the translation that has come forward and the ease of adoption of these interventions or treatments by agencies. And I think one of you already mentioned that one of the limitations might be like with personnel, if they had to be like a registered nurse or OT, master's level training for implementation. But more than that, can you share what are your thoughts about interventionist training manuals that are available, already out there, fully manualized with the intervention, and also about a certification process that ensures fidelity back to the intervention?
That is such a great question. The RDAD program is fully manualized, has all the components that you need to deliver the intervention, all the handouts, all the forms, all the process measures. The training process that we have used, so in Ohio, this is staff. These are staff that are part of the Alzheimer's Association in Washington State and Oregon. It's going to be AAA case managers that are going to be the trainers. The training process that we've used for RDAD and for our other programs we've translated are basically the University of Washington conducts an initial training. There are people who attend the training. The University of Washington is then involved in some sort of ongoing consultation and supervision follow-up, and that's varied from site to site. In Ohio, I believe they've been group consultation meetings. In Washington State and Oregon, what we've tended to do is to have audio or video recordings sent to us of sessions for a full pilot session that is reviewed every session, and the clinicians get feedback about how they're doing, and then subsequently 1 or 2 sessions per case that's reviewed for some period of time to maintain ongoing adherence to the protocols. But there's a lot of questions with this model, and perhaps Sally should take the mic after this and talk about what her experience has been in Ohio with RDAD. But my experience is it's not clear if you have a non-healthcare professional who's been trained to do some of these interventions, how long do you need to continue to provide oversight? We do see that sometimes clinicians are trained, and at the end of the pilot, we say, well, I think you need to do a second pilot. And it does occasionally happen that at the end of the second pilot, we say, I'm sorry, this isn't just, it's just not a good match. You and this program are not, you're a great clinician in your own way, but it's just not a good match for the program, we don't think. So we're sort of clear who we can upfront certify to do the program. But to keep that individual going on a long-term basis, you can't indefinitely have academics at the University of Washington providing supervision to every case. And so we don't really have a good answer for that yet at this point. And again, I'd be interested in seeing sort of, Sally, what you have to say about Ohio.
And I'd also like to add, too, I think Dr. Bass left, but David Bass and Carol Whitlatch is here from the Benjamin Rose Institute on Aging, and they've been working very closely with us, too, so they may have a few things to add because they're the lead evaluators on this project. So Dr. Terry did come out and do the initial training with us. She's been back in Ohio once since then, and we're going into our 5th year. And provided in another training. And then what we've done since then is there was a standardized training that was provided to us from the University of Washington, and several of us in the state have trained additional trainers. And then the other thing we started doing after reading much of the evidence-based literature is we do refresher training and do ask all the trainers to come once a year. And it's just a one-day training. We've been real sensitive to the time and the cost that is attached with training, but we've done a annual refresher training too. So I think that just real quick summary. And then as Dr. McCurry has said, we are in almost sometimes constant consultation with Dr. Terry. We have a group quarterly call that we do where everyone can ask questions, and we receive a lot of technical assistance, not only in regards to the ABC, the behavior modification, just implementation issues, but then the exercise piece too. because many of us don't have the strong exercise background. So we were just talking about the training, David, and how we started doing a refresher training with our dad, and so Dr. Bass has been involved too, so he may have a few things to add too.
I might mention your refresher training, if I understand correctly, because I think it's the same model we've used in Washington, Oregon, is Dr. Terry was involved with the refresher training, but the idea was staff who had already been trained were now taking a lead in that new training of training additional people. So the idea is you are training trainers who then will be able to keep it going on an ongoing basis. And again, the question still then becomes, at what point does the developer step out altogether and all the trainer is now done by the agency or the translation site?
Did you so I've had the privilege of being able to watch these individuals who function as trainers, and I've been amazed at how they've adapted to that role and the innovations they came up with to make the exercises work for people who they may not have worked for just right or didn't match the preferences of people. Did you talk about that? Because, oh, well, I don't know. You should have the mic, not me. Because it relates to Laura's comment, I think. It's a different kind of intervention, though. So I think it has something to do with the nature of the intervention.
So what's happened with the RDI trainers, and as Sue has mentioned, the master trainers have been very, very helpful, particularly as they've been working through this intervention and worked with multiple families. There's lots of experience people gain. And then as a result, people have become very, very creative in regards to how you adapt the exercises to work with people at various stages of the disease, as well as different diagnoses. Because one of the things we've found in Ohio, particularly in some of our rural areas, and not to pick on rural areas because that's a large part of my area, is that doctors are really hesitant to give that diagnosis. And so they might say, well, hear a lot of, well, they might have a little bit of dementia. Is the diagnosis
just a
we
touch.
hear a lot. And not to pick on physicians, I think a lot of it is, this is a hard diagnosis to give. And so the staff have become very, very creative, as David mentioned, in regards to adapting the exercise to individuals at various levels. Am I forgetting anything? And so they've become real creative, and part of that has been, I think, sharing information together as a group. We have conference calls regularly because Ohio's a decent-sized state, and 6 hours from one corner to the next. So there's no way we can physically get together frequently, and so doing it through conference calls and sharing ideas, and then having access to an exercise consultant as well as Dr. Terry has been very, very helpful to help us work through those issues. So we have not tackled the certification issue. I'm just not sure how we're going to do that. So
I just want to say really quickly that the Memory Club also has a replication manual, and it's been replicated multiple times, very similar to what you're talking about, where we require people to go through a basic training and then an advanced Memory Club training, and then they observe a group that's currently ongoing, and then we go and observe them. And then we have people who have been doing the intervention for a while with new trainers or new facilitators on quarterly calls, and everybody learns from each other, and the intervention keeps getting better and more refined. It's probably not, if you're talking about doing the exact same thing every time, always, and never changing it, it's not ideal, but I think these things, people learn from each other and get better.
Well, my comment kind of connects to this whole conversation, but maybe in a slightly different way, which is I think we all appreciate that we have to work harder with licensed health professionals on a lot of issues, but as you're talking about the translation process and community-based environments and interventions or programs, skills that don't require a level of a very scarce resource, which is licensed professionals, it seems like it's going to be useful to have a feedback process to identify who should we select to go through whatever training process we do. How do we articulate the minimum skills, qualities, whatever, that whole selection process. And I think you had mentioned it early on as a challenge, and I was appreciative of hearing you know that people, I don't know how you got at the 7 years, but of expertise in this area, because this is a very, a set of challenging, and persons with dementia across many diagnoses not well articulated could present a lot of different issues. So that said, I'm just curious, do you have any process of identifying, here's the minimum, here's who we ought to be selecting? Because I think we're all interested in people working to the top of their license and looking at this huge and invaluable resource of individuals who have, community health workers, other folks who have very important and valuable relationships within their community. So I just wonder if people have any reflections on that or any plans underway to get us to the tools to identify who ought to go through learning to do a program.
For our translation efforts, we have not set a rigid minimum standard bar. You can find individuals, for example, who are case managers working out there. Most folks have a BA degree, but you might have people that don't even have a BA degree but have a lot of experience working with dementia in older adults. And so, what we say when we're telling sites to select who they think would be an appropriate trainer that they want to represent their site to implement this program, that it should be someone who has a good understanding of aging and dementia. So we don't want someone who's brand new and has been working with just kids. But again, we haven't set a rigid, it's more once someone is in there and we're working with them trying to get a sense of how flexible can they be. When you do dementia work, you have to be able to think on your feet. Things don't ever go the way that you planned. And so some individuals are not as flexible as others, or some individuals come in with a clear model in their minds about it might be a medical model. So, the first thing out of their mind, out of their mouth when a problem with depression comes up is, well, have you talked to the doctor about the antidepressant? As opposed to, doing some problem-solving, brainstorming about other non-pharmacological strategies. So it seems to me that the qualifying background isn't as important as the person who comes into it and seeing whether they're a good match.
I agree. I don't have a quantitative measure of interpersonal skills, but that's what I look for. I want somebody who has very good interpersonal skills, and I can teach them everything else. But it's hard to teach somebody to have good interpersonal skills. So if they come with that, that's actually my baseline criteria.
Sandy, you had mentioned the use of volunteers through your program, and I know that in the Aging Network in particular, volunteers, provide a lot of support and resources. So I'm wondering both how you involve volunteers in your program and how you retain volunteers as well.
Again, retention is not an issue. Once people interact with our group, and they will tell me periodically, I walk away from here every day having gained more than I gave. And I think that it's just such a wonderful group of people to interact with that once you get volunteers in, that's not a problem of retaining them. We do it mostly, because this is a community effort, we do it mostly by word of mouth. You get one person who comes in and has a terrific experience, and then they tell their women's club, or they tell somebody else, and then we have people calling and saying, I've heard great things about your program, I'm interested in volunteering. But we do put volunteers through I think a very rigid and rather structured interview process. I watch them interact before we will actually add them to the volunteer team. So it's actually not even just are they willing, but we sort of make it an honor to be selected to be a volunteer for our program. So people don't take it for granted that just because I'm willing to give 5 hours a week, you're going to always, accept that my time. We actually try to impress upon them that this takes a level of skill, it takes a level of understanding, and we want to make sure you have that, but then we also respect them and respect their abilities. So I think it's sort of an interview process is sort of a self-selection process, but once they're in, there's no trouble maintaining them. I actually could have more volunteers than I do right now. I have people who are willing to volunteer, but we don't need them, frankly. I have a waiting list of volunteers. and again, I think it's because our program, after 7 years, has a great community reputation and people talk to each other.